I am Hein van Poppel. I'm a urologist based in Leuven in Belgium, and I have the pleasure to be the Adjunct Secretary General in the EAU responsible for education. I had the opportunity to come here and to present on partial nephrectomy and actually to defend the place of radical nephrectomy in patients with smaller and even also a bit larger tumors. I have been doing partial nephrectomy since the early 80s already. I had my first publication 10 years later. And then I had an EORTC protocol where I tried to prove that partial is as good as radical. And this is what everybody believes, because if you do a partial nephrectomy, you preserve nephrons. If you preserve nephrons, you get a better kidney function. If you get a better kidney function, you get a better quality of life. You have less cardiovascular events, less hypertension, etc. So patients should survive longer. And this is what all open studies have shown. My study, where I wanted to show oncological equivalence, actually showed that patients that had a radical nephrectomy had a better overall survival than the partial nephrectomy. And this is absolutely counterintuitive and contradicting the results of retrospective studies. So I needed to make a plea to convince people that we should not do radical nephrectomy whenever possible, as is stated in our and in the American guidelines. Well, it's very obvious that a patient who has from the start deteriorated kidney function, glomerular filtration rate that is too low, those who have diabetes, those who have hypertension. This is patients at risk to develop chronic kidney disease and eventually come into the need for hemodialysis, which is heavily impacting on quality and on quantity of life. So if we want to obviate that, we need to spare as much nephrons as we can. This is what we call an imperative indication for partial nephrectomy. So patients in poor general condition, patients with poor kidney function, with bilateral tumors, with a solitary kidney, we obviously need to do nephron sparing surgery. The problem is, by doing that over the years, we have realized that also patients with a normal contralateral kidney, we can do nephron sparing. Then we get even more nephrons spared, and patients hypothetically should live longer and have less cardiovascular events. And my trial actually has shown that's not the case. Patients that are healthy, have no comorbidities, and you give them a radical nephrectomy for a small tumor, they will live as long as those with partial nephrectomy. So patients do not deteriorate their kidney function if you take one kidney out and the other is normal. So this is why I want to convince the urological community that we do not have to do partial nephrectomies in patients that are doing well, that have an eGFR of 90, and that will never get below the level of what we think is what we should achieve. Do not put a patient with chronic kidney disease below an eGFR of 45. When it's below 45, he will suffer quality of life, he will suffer cardiovascular events, and he might even suffer a worse cancer-specific survival, as has been shown by a recent Italian study by Antonelli. It's one of the first studies that showed that if your kidney function is poor, it might well be that your autoimmune system, your system that works against tumor cells, might become deficient as well. So we believe there is an immunological theory behind the fact that the cancer-specific survival might be influenced by the remaining kidney function. As it comes below a certain level, and that level is now defined in the open studies that we had around 45 eGFR. I hope that urologists will realize that if you have a patient with a 5 centimeter mass in his kidney, you presume this is kidney cancer, which is a killing disease still, it's a dangerous disease. You can do a partial nephrectomy on him, but if his contralateral kidney is normal, it's maybe not wise to do it. Why? Because it's useless if he has a normal contralateral kidney. You can do a very safe laparoscopic radical nephrectomy, and he will survive as long. And if you do a partial, you have more complications, more bleeding, more risk of oncological poorer result because of positive surgical margins, local recurrences. So we must avoid to push people to always do radical nephrectomies. We cannot continue to blame urologists who do an easy laparoscopic radical, the patient going home at day 2, and prefer to do complex and more complicated partial nephrectomies.